to Embu and Homer Bay, whose presentations have gone up to Edgar. Thank you both. And their CBOs, and the afternoon will be theirs. We will have a break, and then we'll have a Q&A after that. Okay? And no, you can't have a 2-day weekend. Now, somebody was grumbling that they weren't getting a 2-day weekend. I would quite happily have given you a 2-day weekend, because that's a 2-day weekend for me. MSF said, nah. MSF said your missions would not allow you to have 2 days off. And you think I'm a slave driver. Okay, on that positive note, Peter, Eunice, the floor is yours. Half an hour, research design.
Welcome back to afternoon session. What I'm going to present is research design, and under research design, we just want to know how to integrate research design in NCD management. And this is not a session that we can learn a full lesson about research design. Just a reminder of a few things that you can have in mind when you are designing interventions. And research design is very important because it's a blueprint of the expectation of the findings that you get from the field. Because before you go to the field, as scholars, we normally come up with what we call the research questions. And the research questions, they form a framework whereby you are able to go out there and get answers that are relevant to your study. So I'm just giving an overview. Then what we've come to realize is that some of the research designs that we need to adopt when implementing interventions, they need to be operational research designs because they need to be practical. They need to give as a way of implementing programs that are practical out there. So let's go to the next slide. Research design, as I've said, is a blueprint for answering research questions, and they are very key when it comes to guiding the validity and the reliability of studies in non-communicable disease management. Why is that important? Their relevance is based on evaluating interventions, because once you have the project, you have gone out there, you've started implementing. As I presented yesterday, you need to have an M&E framework that is workable. This M&E framework will help you to evaluate those projects that you have initiated in the field. So, in other words, you are going to the field to answer the questions, the research questions that were put forward when you were collecting data during your surveys in the field. And research designs, they are able to help you to assess the risk factors that may impact your study. And remember, if the study is affected from the onset, at the end of the day, even the interventions that you initiate are not going to create an impact in the field. Then policy impact. Remember, out of the studies, that we conduct. It's where we draw even policy briefs that inform the government, the NGO sector, and another relevant actor who is supposed to implement projects. So research designs can be applicable when you are designing any project, like the screening, soda bans in school, diabetes care system analysis, and all that. Next. Some common research designs in NCD studies. You can use descriptive research designs. And descriptive research designs are very important when actually you are looking at prevalence rates of NCDs in different regions. You want to know about Kisii, about Omabe, Kisumu. You use a descriptive statistic to know the prevalence. And then we have cross-sectional research designs. Like now, you want to know the awareness, knowledge awareness about asthma, maybe in Nairobi County or Kisii County. You pick a certain section, like the informal settlement. You compare with another informal settlement. You see what happens. Then we have what we call case control. And I know you are medics. This is very important to you, where you compare risk factors, like breast cancer cases versus control. And you are able to get data. Then cohort, follow-up studies. You want to look at the urban youth diabetes incidences, periodical. That one is very important. Then we have experimental research designs, and especially when you are testing interventions. And experimental studies are important, especially you guys when you want to initiate projects on education programs, NCD education programs. Then we have qualitative research design. This is very important because here, this is where now you really want to understand the context of a given phenomenon, because you are exploring what we call perceptions, like patient stigma, because you find that you as a researcher, you have to interact, you have to immerse yourself into the patient and extract information using in-depth ways, like it can be key informant, where you have one-on-one interaction with the patient or the person affected. You can organize to have focus group discussions. And remember, we normally tell our students, a focus group discussion should not be like a barasa. It should be like 5 or 6 to 10 to 12 people, because you need to interact with each and everyone equally. You give equal participation in the interaction process. And we normally say that no answer is wrong in a focus group discussion, so that we avoid that aspect of inferiority complex. Someone might think the answer I've given is important than the answer the other person has given. So such another way is observation. You can observe. You are looking at issues of income level. You look at even the facilities at home, the way of dressing. You want this person to buy a certain medicine, and the way the person even is dressing, you wonder whether he or she can afford. So qualitative research designs are important. But nowadays we have come to realize that one of the most important research design that is applicable when we want to have sustainable interventions is mixed method approach. Next. before that. Is there another slide? Yeah, that one. Mixed method approach in NCD management. Why am I saying it's very important? Like now, if you really want to know maybe the demographic characteristics of the patients that you want to bring an intervention, you can start with quantitative. The quantitative is able to, you are able to extract numerical data from the participants, and now you bring in the qualitative aspect. Quantitative brings in numeric, and then qualitative brings in the descriptive, the narratives, the verbal talks, and now you combine the two. Like now, how old are you? You say the age. And you can even use the Likert scale, greater, greatest, and all that. Once you have the data now, you can have open-ended questions. Qualitative methods prefer open-ended questions, whereby you get the information, and the person who's giving the participant who's giving you the information is able to give more explanation about this particular issue. So at the end of the day, you are able to justify the quantitative data. So they play complementary role when you are getting information, because qualitative and quantitative, they both capture how many is quantitative and why. The why question now brings in the narrative. Best for complex social determinants. For example, medication non-adherence. How many times do you take in a week? Maybe 4 times. How many times were you told to take in a week? 6 times. Why are you taking less? Now you see how the why question has come in. The why question will explain the reasons behind not adhering to the prescriptions given. Then quantitative is in form of percentages of non-adherent parents. Then qualitative gives the reasons why you are not adhering, like now the aspect of stigma. And as a social scientist, you don't just stop at that word stigma. You will want to know, how is this stigma? You dig deep until you know this stigma is brought about ABCD. Then that fear, the cultural beliefs, you really want to know what kind of cultural beliefs that are affecting adherence of patients to medicine. Then at the end of the day, you are able to come up with interventions that are going to address the issues of non-adherence. Remember, non-adherence is the major aspect that affects treatment and management of NCDs. Drugs can be available, but you find people are not changing in terms of their health status. Next. Key considerations when designing NCD research. You must have clear objectives. For example, school nutrition program impact. What do you want to achieve at the end of the day? Then you must have a clear, as we said, smart objectives to guide you in that. Then issues of ethical approvals, essential. So that has to be very clear. Like when you are dealing with the minors, there is what we call the assent. The parent, the guardians of the parents have to assent for you to get data for analysis. Aspects of sampling is very important, stratified by location, gender, and age. Issues of sampling procedures, sample size, and all that have to be very key, because if you don't sample well, whatever you get from the field can be biased. And remember, we say that the findings that you get from the field should be generalized. So if you don't sample well, the results can be biased. And if they are biased, the interventions will be biased. So you have to be very keen when doing that. Then you also need to understand the tools that you can use, like now the combo toolbox, whereby you are able to get data in a digital way, and it's stored in a server that can be accessed even later and analyzed, reanalyzed, and all that. The World Health Organization step, you need to know all that. Feasibility is very important when you are designing a project, a study. Budget, you have to consider budget. You have to consider the aspects of politics. Everyone has to be involved, and it has to be clear to everyone, and also time frame. You don't have to be in the field collecting data for a whole year, and you are dealing with an emergency program. That's why we have what we call rabbit studies. You are in emergency situations most of the time. Rabbit studies, yeah? Rapid assessment. So you do it very quickly because you need to intervene. So I have to consider all that. Then inclusivity is very important because you have to involve the marginalized populations, people living with disabilities, those who are affected by the disease, for instance, the elderly, all those who are vulnerable have to be part of the process in the study. Next. So from research to policy and practice, remember, research has to be translated to a policy. And that's why when you are conducting a research, you must come up with even a policy brief, which you can share with stakeholders. And that's why we started with stakeholder management. Because the stakeholders have to own the policy. Once they have owned that policy, it can now be put into practice. Practice means intervention. It has to intervene. And at the end of the day, you have a good project that is sustainable. And as we said, purity will tell us how you enter and how you exit. As you exit, do you still leave people implementing the same project and getting the positive outcome or impact out of that? If you are able to do that, then we can say that you are doing well. So what we can say, and as I can tell my colleagues here and you students, good research does not end in journals. Like now here in the academia, we are just told that if you don't publish, you do what? You do what? You perish. Here in the university, good research does not end in journals. It ends in changed lives. You have to impact the lives out there. So ensure that any research that we do with the academia, we work together with you. The research that we have, it impacts the lives of the members of the community. Having said that, I'd like to invite my colleague to come on board and talk about applicable methods when we are talking about data collection. And I would like her to use her approach of narratives, using art in terms of collecting data and a few aspects. Thank you.
Mine will be other methodological approaches that we can use in health intervention. That is introducing oral literature narratives, a culturally grounded approach to health research and intervention. Kindly. All right. No, there is advised share the most recent slide, sir. So when we talk about oral literature, we are talking about spoken word. We are talking about stories. We are talking about myths. We are talking about songs. And these are, they are very important for heritage preservation because they help individuals to rely on their memory. You are able to memorize, you are able to perform, and you are able to interact with the community. And when we talk about narrative inquiry as an approach, it is a method whereby we focus on understanding personal stories and experiences to talk about the NCDs. So we are using oral narratives in health research and intervention. So when we talk about this approach, this is whereby you bring stories. You talk about patients talking about personal experiences, or community health workers talking about their personal experiences about NCDs. And these, when you integrate oral literature into NCDs interventions, remember oral literature has the performative aspect. It engages the community. People, we are supposed to move beyond the informal part, that it's not all about informing people about NCDs. We need to engage people to take part in these stories. Next slide. When we talk about oral literature, this is whereby you do, you take a deep inversion in the cultural context. If you want to get the stories of Abagusi community, you become part of the Abagusi community. You learn about the histories of these people, how they talk about NCDs, and do they have other measures or other management tools of these NCDs. So when we talk about oral narratives, this is where we focus on the cultural aspects. You become part of that culture. If you want to do a research in Kisii, you'll have to live in this count, because there are those taboos, there are those beliefs that are surrounding these NCDs. And another thing we need to know, when you do an intervention, you need to understand these people, understand the age gap, understand their preferences, because you could be using the wrong method to address an issue. If you will not understand these people, you will get wrong perceptions. So you as a researcher, be part of this community. Immerse yourself there and feel like you are among the patients. And then you will get to know their issues. What are the key methodological methods for conducting oral literature research in a health context? When you want to do conduct a research in places where we have high levels of NCDs, one of the things you need to do a thorough field work. That's what I've said. Go to the community, understand the context of these people, understand the levels of these conditions, and design ways of managing them. Come up with your personal interventions. Because if you are within Kisii town, you can't tell a person that you are HIV positive. It is a taboo. Of course, you could be knowing this person is sick, but there should be a way of addressing. So another thing you can do, recording and transcription. The first thing we have said is you can use fieldwork, do recording. Let these people narrate their stories. Let them tell you the personal experiences about their conditions. So for you, you record and transcribe the oral narratives. Then do analysis. So you interpret the transcribed narratives within their cultural and historical context so as to identify themes, values,
and how they influence health beliefs and behaviors. How will you collect data if you have decided to use the oral narrative approach? So one thing you can do, you do participatory and culturally sensitive methods. Apply these methods because as a researcher, when you are collecting data, more especially in regions whereby culture is a key factor. Like my presenter said yesterday, that there are places you cannot be given information because of the cultural beliefs surrounding NCDs. So you must fully participate and be and apply culturally sensitive methods. So one of the key components here, you do fieldwork and do participant observation. I've said already you'll have to immerse yourself in Kisii community, live among those members, and participate in their daily life. Once you do that, you'll be able to build their trust, and you'll be able to have a nuanced understanding of how oral narratives help or talk about health and illness, and you'll be able to understand what are the major issues that are affecting Kisii as a community. So when we talk about another thing that you can use narrative inquiry and in-depth interviews. That is another method. If you want to collect data, you use narrative inquiry and in-depth interviews. So you do interviews with individuals. Remember, there are those people who don't like a crowd. Like, you cannot ask questions about my personal life. So do individual interviews. Ask the traditional healers, because we have already said that in Kisii community, we have traditional healers. There are diseases that we believe they are caused by maybe, I'm sorry to say, witchcraft. So people believe that we can use the traditional methods in healing these conditions. So get to interact with these people. What are their perceptions about these diseases? So again, engage the religious leaders. What are they saying about NCDs? Talk about elders. For you, before you get into a community, you must seek permission, because you are going to collect information about a given community. So you'll have to engage the local leaders, and it is very important. Do you know why it is very important? You are collecting personal stories about their health conditions. So you'll have to engage these people. Another thing you can do, another method, is focus group discussions, the FGDs. So it is very important when collecting, for collective storytelling and discussions, because it assists you in uncovering shared beliefs, community norms, and group health behaviors. Put people into groups, let them discuss, let them give stories about NCDs. Another thing you need to do, of course, my colleague talked about ethical considerations, that before you do all this, there are things you need to adhere to. You need to have an informed consent. You maintain, you ensure that you don't disclose information, personal information about your patients. You ensure that you do not harm your patients. Another thing that you need to do when you are collecting data, I've already talked about the need of these methods, the ones I've said, that is the narrative inquiry and in-depth and interviews, focus group discussions. It's because you need to get the personal stories surrounding the NCDs. Remember, we are finding a way of managing these conditions. Yeah. Next is, now, when you are doing interviews, you need to have specific questions that will guide you when you are doing this narrative research. So one of the questions that you might ask is what stories do people tell about the causes of diseases like diabetes and hypertension? How do traditional narratives explain changes in health over time or the onset of chronic conditions? Another thing you can talk about, what proverbs or sayings that exist in Kisii culture that relate to diety, physical activity, or alcohol consumption. Another question, are there traditional songs or chants used in healing practices, and what messages do they convey about health and illness? Those are some of the questions that can help you when you are doing a narrative research approach. And then another thing that we need to talk about is the designing phase, or the design phase. Now, how do you translate these narratives into culturally sensitive interventions? We have principles here that need to guide you. One thing that you need to take into consideration is the principles of culturally sensitive intervention design. Okay, you can have this kind of design. If you want to, for instance, you can have what we call interventions that go beyond simple translation to include deep structural changes. So for you, you need to integrate the cultural values of Abagusi community. Another thing, you must ensure, if you have decided to have a design that is culturally sensitive, include the cultural beliefs, and practices. Another aspect is community engagement and co-creation. Ensure that you involve the community members. I've already said this. And ensure you have a holistic approach. Adopt an approach that aligns with the Kisii worldview, integrating physical, mental, emotional, and spiritual well-being. The second design that you may consider a design that is called narrative-based health messages. So if we are talking about oral narratives, we are expecting to have a design that talks about personal stories, messages that are there to convey health messages. And remember, it is the NCDs. So for instance, talk about community heroes, people who have managed to survive these conditions. We have, my friend here said that he has learned a lot of ways of managing his condition. Those are some of the community heroes who can talk about. So bring on board the community heroes. There are people who have managed cancer stage 4. I can give an example. He's normally a public speaker who talks about when he was diagnosed with the cancer stage 4, he thought that he was to die the next day. But believe me, he's a very important person of light. He talks about how he decided to let the sickness go. And up to date, he has never understood how it disappeared. So have those stories. Have stories about the community heroes, and let them talk about how they have managed these challenges. You can as well have proverbs and saying, like someone has done a research on disability. We have metaphors on disability. So bring on board proverbs and saying that talks about health, that talks about diety, and that talks about lifestyle, so that you can make these people. Remember, the use of metaphors and proverbs are a form of oral narratives that can make individuals to memorize. If you say one statement, I can easily use this statement for the entire of my life. So in such a kind of design, ensure you use proverbs and saying that touches on health-related issues. Use proverbs that touches on dietary related and lifestyle related. We also have songs and chants. We sometimes, I know you have attended music concerts, maybe in your country. The emphasis is on political messages. But it's high time if you design a research intervention method, ensure that you bring songs that have actually health information. For instance, ensure that if they are doing a traditional song, they can demonstrate how individuals can use fruits in the management of a given NCD. So through their demonstration, through their performances on stage, you can easily take a message of what they are doing. So encourage the use of songs and chants that focuses on health-related messages. Next, please. I've already said developing a narrative-based health message design. Let's move next. So we have what we call the implementation phase. I've already said the design phase. How now do you deliver the narrative-driven NCD projects? So for you to deliver on this, one of the things that you need to consider is you use approaches like the community-led approach. First of all, you need to empower the community health workers. The community health workers are very essential in delivering the narrative-based health messages. Remember, we already said that in Kenya we have the community-based workers, and they are there. What they do in the community, sometimes they give medicines to the patients. So you can use these people in passing health-based messages. When they go to various houses, tell them to use stories. Use stories as a way of reaching out to the patients. And another thing, under the community-led approach, engage the local leadership, because they are very important. You cannot come to a community without seeking a permission. That is under the implementation stage. Next, please. Another thing, under implementation stage, we have said you use the community-led approach, then look at the channels for dissemination of this information. How are you going to pass this information to the community? You can do community gatherings and ceremonies. Where there is a community gathering, you can do songs that touches on health-based conditions. You can as well form groups whereby you bring small children to participate on songs that touches on lifestyles and diety. Another thing, you can hold traditional storytelling sessions. In those whole days, we used to have evening sessions, storytelling sessions, whereby parents could, not actually parents, it is the grandparents used to meet the young children. They could narrate stories. So you can use that method. You can bring the people with NCDs, engage them, narrate stories. In those days, they used to say, long ago, there used to be this. You can use such approaches in addressing those stories. We have the local radio and media. We have these programs. We have programs, and you as an individual, you can have a talk about NCDs. We have the local channels. You can design posters to create awareness, messages that are touching on a given NCD. Another thing, you can have intergenerational dialogue. And because of time, I've been warned by Professor. Let me talk about the last one, which I feel is very important. So I have a question, and you have such a kind of the last slide kindly, question and answers. You could be asked to develop a research question, objectives and methodology for the following statement. And here you'll be using the oral narrative approach as an intervention criteria. So you have this statement: mental health conditions are significant NCDs burden in Kisii County. Alcoholism contributes to rising stress levels and mental health issues. Traditional beliefs may attribute mental illness to spiritual causes or witchcraft, leading to stigma and delayed biomedical care. So you can develop a research question, and what you need to use is an oral narrative design. So focus on the objectives, which kind of objectives can you have, and the kind of methodology you can use in carrying out the project. So that is the second question for you. You can think about it and come up with the most appropriate methodology in a health intervention. Thank you so much.
Primary research is not a no. It can be done, but you only have 11 months from a standing start to completion. And you can't afford to be going back to the Research Ethics Committee multiple times to get it approved. So when we do the research into practice module, and when you're doing the start of the dissertation, this research is fascinating. You get some really interesting stories, and I have a couple of questions for Eunice about problems I've come across. When you're thinking about your research subjects, as fascinating as this is, you've got 11 months. And you've got to bear that in mind, okay? Let's move on to the most exciting bit of the day. We are now going to, I offered them the option to choose their sequence, and it appears that we are ladies first again, and Ember we're going to showcase. So Purity, Shem, the floor is yours. This is the second stage of the 3-stage about our 2 counties. Purity.
Thank you. Good afternoon. Oh, thank you so much. Good afternoon. I have which fruit today? We picked pineapple. No, pineapple is on the ground. We pick the which tree? Which fruit is high up there? Coconut. Coconut is a fruit or a vegetable? No, a banana you have to pick and put it in the house to ripen, so it's near. But is coconut a fruit or a vegetable? No, let's pick this, what is it called? The orange yellow that is a bit delicate. No, not mango. Yes. Let's pick, because you know, if you drop the papaya, then you can't make anything out of it. So let's stand up and pick the papaya. We call it popo. Sumbua and I call it popo. Yes. So what we want to do is that we want to pick the highest popo and delicately put it in our basket. Our basket is on the floor, but I think for you, because of the bench, you can have your basket nearer. But for me and Shem, the basket is right on the floor. So we have to pick it. Huh? So pick your popo. High up there. Both hands, because it's very delicate. Yes, then bring it down slowly to your basket. That's the first one. We have to pick 5 because we want to make a pawpaw pie for the whole class. Okay, so we pick the second one. The second one. Who is not picking? I see someone not picking. It's high up there. Yes, like that. Both hands. Then pick it slowly. Bring it down. Now you have 2. Is that enough for your family? Oh my goodness. Okay, that's enough for your family. Thank you so much. Oh my goodness. Okay, so hope we keep awake and alive this afternoon. It's not very easy, but we will try. So this afternoon, I want to speak to you about the Embu project, the MSF intervention in Embu with the NCD project. Yesterday we had just a small touch of it, that the project was a project by choice. MSF chose to go to Embu. There was no rush, there was no hurry. We wanted it for our own reasons, but of course, at the end of the day, the benefit is to the patient. You have my slides? No, today is day 2. Day 2. Anyways, I may not use them so much. So what happened is that in 2017, MSF Belgium was closing a HIV project that they had ran in not Madare, in Kibera. Kibera is one of the informal settlements in Nairobi. It's highly populated, and the project that MSF had ran there was a HIV project that had gone, I think, for about 20 years. So towards the last 5 or so years of the project, there were complaints from the patients, who most of them had hypertension, but some others had diabetes, others had epilepsy and asthma. And whenever they came to the HIV clinic that was 100% manned by MSF, then they would be sent to to another clinic to have their hypertension and diabetes managed. And the patients did not like it because they had to move to another section. They had to go and wait again to see a different clinician. And most of the time, the clinician who treated their hypertension and diabetes did not ask about their HIV. So there was a bit of interaction with the medications. There was a bit of overlap on when to take the medications. So most patients actually said they want to be managed by one clinician or in one center for all their conditions. And again, comorbidity, hypertension and diabetes is quite a lot. So someone had to, and so this got MSF thinking. We have a concern that we need to address for us to see NCD patients in our HIV clinic. But then MSF had developed a lot of expertise in HIV management, a lot of research, a lot of guidelines and information material for patients with HIV, but none for NCDs. So what MSF started to do was, first of all, to get an NCD reference. So there was an office that was created in Brussels, and an NCD referent was hired. And the main role for this person was to look at the stories coming from the field regarding the NCDs and the difficulties that the clinicians were facing in managing NCDs. And one of them was that most of the people had forgotten everything about NCDs because all the efforts and the concentrations were on HIV management. Then again, this person was also to review the national guidelines and see what the Kenyan guidelines say about management of NCDs. One of the realizations was that for every condition, there's a different guideline. So we have the cardiovascular guidelines, we have the diabetes guidelines. We still do have them like that. We have a guideline for epilepsy. Epilepsy was actually under mental health. That was the most confusing one. Then we have asthma under the lung infections. So then it was so difficult for the clinician to jump around guidelines looking for what to do. But the most important thing about the guidelines was that they were at a very high level. Most of the guidelines talks about drugs that were only available at very high levels of healthcare in the country. So then the patients who were coming to the clinic were not able to have these drugs available at Mbagathi Health Center, which I think is a level 3. I'm not so sure, but the drugs are not available. So they got a prescription, and that brought another problem. Wherever they got a prescription, then they never went for their drugs. So this is how the interests for MSF Belgium to get involved in NCD care came about. Then on the other hand, we have SAMU. You know SAMU, South Africa Medical Unit? I believe so. Some of you may be. So SAMU was developing training aids for healthcare workers within the HIV programs. And they felt confident on what they had done because the mentorship methodology for HIV had been tested across several MSF projects. And they felt confident on the methods of teaching. But then they asked if they could try this methodology for teaching within NCD conditions or other settings other than HIV setting. And so when MSF was designing the NCD project in Embu, it was to meet these two objectives. One was to increase the expertise in NCD management among MSF, starting with MSF Belgium, but something that would be scaled to all MSF sections and that would be replicated and adopted within MOH settings. And then number 2 was for the mentorship methodology to be tested outside the HIV field. So the mentorship methodology mainly was a teaching aid for healthcare workers that is slightly different from the classroom teaching. Traditionally, we would be called for a lecture, for a training that would take 5 days. Teaching in a classroom setting. And after the 5 days, we did a pre-test, so we'll do a theoretical post-test. We'll all pass, get our certificates, and go to the field. When we start working with the patients, it's difficult, it's different from what we saw in class. So through the mentorship methodology, it was found out that only 30% of learning happens in a class teaching. And the 70% is in the practical area where you have to sit with the patient, do the blood pressure correctly, see the differences in blood pressure reading for different people. How does it affect the patient if the cuff is not properly placed, as opposed to just knowing that you need to place the cuff properly for you to get an accurate blood pressure reading. And so in Embu, so yeah, the Kibera project closed. So because then it had already been decided that this project was closing. And the coordination team in Kenya asked where else, or what else do we need to do to fulfill these two objectives? And that's how the assessment was done in all the counties. Yesterday we looked at the pre-requirements for this project. It had to be in a very stable environment, so as to test these things, develop the guidelines and the tools, and see that these tools were actually applicable. So after the assessments that were done, Embu was found out to be the most convenient and appropriate place for this project. So in 2017, all the documentation, the corporate documents, the preparation for start of a project were done, and the project was actually started in 2017 March. So before then, there was hiring of healthcare workers. MSF was looking at people, clinical officers and nurses who can mentor. So people who have knowledge and ability to manage NCD patients for those 4 or 5 conditions, including COPD, and people who are able to mentor or teach. So what happened? We had very vigorous interviews. They were the worst. Oh, they were the worst. Yeah. Yes. Personally, I felt like I'm being taken to my training in medical school, but it was fine. So what we were looking for were the qualifications of course, people who can manage NCDs, people with experience in NCD management, but also people with experience in teaching, mentorship, and coaching. And eventually, the team was made up. In Embu, it was a full project with experts on. The experts were the field coordinator, the PC. The deputy PC was a Kenyan. I acted as the activity manager for the 5-year period. And then we had the mentors, clinical officers, nurses, and health promoters. So one of the aspects of mentorship approach was that people would mentor people of the same cadre. So that clinical officers then mentored clinical officers, nurses mentored nurses, to remove the barriers so that they can understand one another. I think we were told we learned by seeing. So it was possible, or it would have been made possible for the MOH nurses to believe that the nurse can also manage NCD patients if the MOH nurse mentor is managing them. So we had an evaluation. So basically the mentorship methodology has its own format. It's in modules, it's in sessions, and all this teaching and training material for mentorship is available for use in case any of you would want to. We have these things in store with MSF OCB. There was an evaluation of the mentorship methodology that was done by Dr. Paul Stokes from the Stockholm Evaluation Unit. And the main aim was to check the appropriateness and effectiveness of the defined mentoring framework. It was very new to MOH that we have to do this kind of teaching. And so, in summary, the finding was that EMBU mentoring program was found to be an effective learning and teaching strategy that has enabled mentees to develop new NCD knowledge, skill, and attitudes. So in essence, the mentorship methodology has been proven to be successful in educating people who've not been practicing, or people who want to decentralize this kind of service to. So if you have, like we discussed yesterday, the level 2, level 3, nurses and clinical officers, eventually it's only the medical doctors who handled NCDs, but now we want to shift this task to the nurses and clinical officers. So mentorship methodology was a good way to do that. But coming back to the program aspect or the management of NCDs, what did MSF do? So we started enrolling patients in these lower level facilities. I told you yesterday we had around 7,000 patients towards by the end of the project, and all these were, 90% of them are patients who were already in care, so they were already on medications for NCDs. So one of the questions MOH asked us is, why aren't you going out to screen? MSF did not screen for NCDs at the community level. And it's because during the assessments, and of course from literature, it was realized that screening would bring in a lot more patients to the system, yeah? And already the system is quite burdened. So we chose to work with those patients who were already in the system. So someone could ask, do we go screening to the communities? Do we go management of those who are already diagnosed and then add the component of community education? So that's a decision that you would have to make at a project level. Yeah, that's about mentorship. Yes? It's fine. It's fine. Actually, the slides confuse me a lot because there's so much to say, but well, we'll manage ourselves. Yeah, so every time we did mentorship, it was the MOH mentor, the MOH mentee, and the patient. But we also had a session on classroom teaching, just to talk about the facts, and then we went to the practical session where we met the practical objectives of the teaching session. Where was I? Where was I? Mentorship is, we are done with mentorship. Yes, what else did we do? Yes, yeah, so some projects will argue, and MOH in some missions might actually push for screening because of the numbers. But then are we able to handle the numbers if we screen, especially for hypertension? Most of the people in the community are just living with some level of hypertension, but do they all need to go into the system and start on medication? One of the other things we realized in Embu County is that when we started the service, when we started offering NCD care, we needed to supplement MOH with the medicines. So we started supplying the drugs. At the beginning, 100%. And then in the second year, we thought that MOH will start picking up because we were sharing the data, we were going into their meetings and discussing the budgetary meaning of the support on the drugs. But even towards the end, we realized that MOH is not going to supply any NCD drugs. And at that point, in fact, at the point that we were leaving, one of the main questions from the patients was, who will give us the drugs that you have told us we have to take on a daily basis? Yeah? So supply of drugs was a very important component for us, and the drugs that we supplied were all in line with the guidelines. So we have the guidelines that is setting the standards on what drugs are going to be used at the primary healthcare level, and we are supplying those drugs. At the same time, we are sharing data with MOH and advocating for MOH to take up some element of supply of the drugs. But as we saw yesterday from my discussion and from other people's presentations from Kisii, we have such budget constraints that putting money in NCD is it's a very tall order. It's almost not possible. And sometimes when MOH supplied drugs, then they would look at the cheapest of the drugs. And some of them, yes, are useful, but are not the core drugs for stabilization of the patients. For example, furosemide, Lasix. It's very cheap in the country. So they'll supply cartons and cartons of Lasix. But then how many patients, what proportion of the hypertensive patients are using Lasix for their control? Very little. So as we worked along, we kept having discussions with MOH. We sat on the NCD technical working group at the county level and at the national level to share our data, to share our findings in the field, and help MOH to better strategize and better plan for the NCD drugs. Then lab monitoring became the next issue. So we want to do the HbA1c for the patients. We want to do the creatinine clearance for the patients. It's not available. Normally in level 2, level 3, the labs that are provided are very limited. So you find that you want to do a HbA1c, it's not available. But then how else do you monitor your diabetic patient? So MSF supplied, I think meat is from the lab, yeah? Yes. So we supplied the point of care lab equipment to check the blood sugar, to check the HbA1c, and to check the creatinine. So MSF supplied the point of care. They're easy to use. The nurse at the nursing station can just check it on the table, and it was very appreciated, very easy to work with. The problem came at the end of the project because we were supplying the cartridge and the machine. So MOH was not able to continue supplying the cartridges. So HbA1c then became inaccessible to the patients again. yet we know the importance of that. Now, through the community-based organizations, they've organized and bought 2 machines that they've placed at the central locations, and the patients can access the HB1AC at a cost through the CBUs. But that which we donated to the MOH is just nicely packed in the shelf. They cannot afford the cartridge. For creatinine clearance, it was completely stopped because the point of care machine is not even supplied in Kenya. We don't have that kind of a machine in Kenya, so it's no longer supplied. So as we continue to manage our patients, we still had a very strong collaboration with MOH. For us, all this management is being done in MOH facilities. There was no standalone MSF facility. So every day we woke up and we went to the MOH facilities. But again, the level 2, level 3 are far from the senior MOH managers, the county health management teams. So we also acted as a bridge just to pass what we are receiving from the patient and from the healthcare workers, to be the voice of the healthcare workers. In some places we didn't have BP machines, and MSF had to supply this. So we go to the county and ask, how come we don't have BP machines? Some small but essential tools that are required for diagnosis and for management of patients, not just NCD patients. All patients require to have a BP check. So we also were the voice of the healthcare workers at that level. And this went on for 4 years. Oh, sorry, I forgot to say at the beginning we had an MOU, a memorandum of understanding with the county, that we would be there for 5 years. And we were discussing the other day, when you get in, how do you get out? It's usually very difficult. So the MOU was a 5-year, for a 5-year period. And the main reason for this is because with the experiences with MSF, there was that worry of once we get in, then how will we get out? So, and again, because we did not have proper targets for monitoring the project progress, then we used the MOU as our exit tool. The slide 7, please, if you can. So there was a lot, yes, this one. There was a lot that was going on during that project period. And this slide just shows a merge of the teaching and the service provision and the journey of the project up to the end. So maybe at your spare time, you can go through this slide, and if you have questions, then I can answer. Next slide, number 8. So we consider our project to have been a success. And what were our main success factors? And of course, our aim was to integrate NCD into primary health care. So number 1, the model of training that we chose to use, the mentorship methodology. So if you are to bring down services to the lower levels, then you have to put in place a training schedule, some level of training for the healthcare workers. They could have been trained during their school time, but most of them have not managed NCDs in a while. Yesterday we were talking about sickle cell. If I find myself today in a sickle cell prone region, I may not even know what to do, yeah, because we have regional conditions, regional problems. So it's good always to have a program for training. Clinical mentoring worked well for us, and towards the end, we had quite a number of people who were trained and were able to manage NCDs at that level. Then the second success factor for MSF was the simplification of the guidelines. So what was happening is that at the coordination level in Nairobi, we had an advocacy manager and the medical team that was helping us to present our findings and our experiences from EMBU at the national level. So when they have the national meetings, then the voice of the primary healthcare level was heard. We presented our guidelines. We presented the differences that we saw in the national guidelines and the MSF researched guidelines. And towards the end, we developed the easy-to-use guideline. They are there now, step-by-step guide for the management. So they'll show you if someone comes with a complaint or they want to check their blood pressure, so what do I do? what is a high blood pressure? How do I make a diagnosis of hypertension as opposed to just one reading of high blood pressure? And that is easy to follow. They have the guidelines and they have the clinical reference charts that they can use. And those have been adopted by Embu County government and is producing for other facilities other than what MSF was in. Yeah, the visual support. So if we have the guideline and then we have the flip chart, short form of it. So when I'm seated, I can quickly go into the green coded part that is for asthma, and I can quickly check my asthma doses, or I can quickly check when I need to change for my patient the asthma doses. Yeah, and then stable NCD drug supply. I said we struggled with that even towards the end. But then for us to monitor our patients and for us to say that the guidelines are proper and working, we have to provide a stable NCD drug supply. And then patient education and support, very, very important. Patients are wise because we are patients as well. If I'm going to see my doctor today, I'll probably be at my best behavior. So what we realized, shame one time defaulted medicine. Yes, but when they came in, they would tell us, oh, no, I've just taken my cup of tea, so that's why my sugar is high today. Yeah, but with patient education, they understood that it's for my own sake. It's not for my doctor's sake that I should control my sugars. And we found the patient support team to be the patient support to be very important in managing NCDs and in making this successful for us. So next please. Yeah, I just wanted to put up a slide because most of the MSF projects today are working with MOH. And or maybe some of you are standalone MSF projects which are easy and super to manage. But if you are to work with MOH, then you have to have a strong collaboration. They must understand all these aspects, all these steps that we've just discussed. Otherwise, when it comes to the time of departure, then the patients are looked at as MSF's patient. To a large extent, even with all the interventions and the involvement, some would just say, your patients are waiting outside. Wale wagonjwa wenyu, wanangoja pale. Wagonjwa wa MSF. And then I would say, no, they're not MSF patients. We did not bring anybody. They're just from our community. Yeah, so it is easier said than done. But for me, what I saw work and what I believed in most is engaging the MOH and the community at every step of the way, and it made it easier. And even the patients, for the patients to understand that they need to demand, and that's why we had the patient advocates, they need to keep demanding for service from MOH, not MSF. When things are not working very well, they need to ask from the government, not from MSF, because MSF was there just to support the government and not to take over the full management of the government. So tomorrow we'll talk about the CBUs. Or maybe I have a lot more time. Do I? Yes. Okay. So just the last slide on this one. The key message is that it is possible to decentralize NCD care into primary healthcare level. However, we have to have an empowered healthcare worker who has the capacity to make the proper diagnosis, treatments, and manage NCDs. But we also have to make available simple and easy to use standard operating procedures and guidelines, have adequate and consistent supply of NCD drugs and supplies for the primary healthcare facilities. One of the biggest challenges when a doctor, a clinician has to give a prescription. It's my worst experience. I hate it. When I see a patient, I have to tell them, no, you have to go and buy this one. Most of them will not buy. And when they get to the chemist, there is a change of prescription. There is the altering. There is the buying one and not taking. If someone is on a combination, we didn't use fixed dose combinations. We used the single tablets. So if I give metformin and maybe glibenclamide, they'll go and they have little money. So which one is the most important one? and they're told this one. So they take one. The next time they're coming, they're not controlled. So at the health facility level, it would be nice to have all the supplies that are required to manage their conditions. And then, of course, invest in health promotion to empower the patients to take charge of their conditions. So, next slide, please. So maybe I'll give Shem a minute. This is your facility, Shem. This is Kanja Health Center, to tell us how, from a patient perspective, how they experienced the MSF activity in Embu County. Then tomorrow, not tomorrow, on Monday, we'll talk about the formation of the CBOs and what was left behind by MSF in Embu County. Thank you.
Okay, thank you. Since when the MSF came to our place, this is Kanja, this is our facility. I can see these people, I understand them. These are my neighbors, some of them, and I'm my grants. So I may say, since the time when MSF came to our place, majority of us were not taking medicine, majority of us were not having those conditions controlled. Some learned, some had no money to look for services, but when they came, it was free. Both, they supported in everything. They came with the drugs, they helped our clinicians and our nurses to take care of us. We were happy. They preached the gospel to the community held it, supported them. We were enrolled. I am sure my file is number 585. We were managed by files. So there was a follow-up of how you are progressing. I have got my notebook. I have got my book, my booklet, which indicates my condition from the beginning up to date. It is there. My record is there. So even if a nurse comes, I would present my record to him or her. She would look from the beginning to today and find out how I'm progressing. So to the MSF, we are grateful. You have helped us a lot. Before you left home, before you were about to leave, you have prepared us enough. We have gotten drugs that before MSF left, or before they have not fully left. We were given some drugs worth more than 4 million to our CBO, which you are taking, and we are taking it maybe I may call it, we are operating a CBO, which has drugs. We have got the CRPs at different centers. We have we get medicine from meds. That's when we get who supply us with medicine. We keep it at our center. We have got 6 facilities. The central position is Kairuri. We put all the drugs there. Then from that point, we distribute drugs to other 5 facilities, because parents are very far. They cannot manage to come from drugs from that point. So there are CRP, that's a community living pharmacies, in those health MH facilities. We have got our nurses who looks at us, who manages us, and the pharmacists. But in those facilities, we depend on nurses or the CEOs in those facilities, and the pharmacists also. We do not have our own. We cannot be able to employ them. We cannot even be able to pay them. So we are grateful to both the MSF and the MH at our levels. Otherwise, were it not for these people, maybe I myself, I would have been transferred somewhere else. But God is great, I'm here today. That's why I preach the gospel that let's follow our directives from our nurses, from our people who know about these things. Let's live accordingly. Let's do practices, and things will be okay. Otherwise, thank you very much.
George. Thank you to Embu. George, Edward, the floor is yours. some of us old men are needing a comfort break, so take a breath, get yourself together while we come back.
Good afternoon. You good? Should we draw fruit? I think me and Edward, we are not good. So I'll take you through what we do in Homa Bay. It's a different approach from still the same simplification. So that is Homa Bay County. Yeah, so tomorrow those who will visit, make sure you go to the lake. I don't know whether that is Rusinga Island. So I'll take you through what we do. Yesterday I took you through the problem, like the statement of the problem, which you can see that in 2018, you can see the mortality was 22%, but in 2019, it was 29%. And also you can see that is for NCD related conditions. Also you can see from the admissions, you can see that we had 20% in 2018 and 2019. We had 26%. So in 2019, you know the map period, I think OCB they call it arrow, OCG don't know. So when we do the budget cycle, so we presented this so that the Homa Bay project was old. We were doing HIV, we did hospital, we decentralized, but then we saw that there is an increase of NCD related complications coming to the IPD. You know, those who come to IPD, they must be needing to be admitted because maybe they have complications. Most of them have complications. So we were to implement in 2020, but because of COVID, we delayed, so we did it in 2021. And also during COVID-19 period, those with NCD, also there was a significant mortality, especially when Delta variant came. So we shifted the project from focusing on HIV to, okay, I don't want to say advanced HIV, because advanced HIV disease, that is to chronic disease, that is the word, to chronic disease. So advanced HIV, because still Homa Bay, as I said yesterday, when we went there in 1997, the prevalence was 35%. In 2023, it was 15.3%. So still we have a high prevalence of HIV in Homa Bay. And also, now we saw most of the cases, like yesterday I presented to you that kidney related morbidity is the leading cause of mortality. Even last year at 16%, stroke at 15%. Another thing maybe I forgot to say, from IPD, like last year, palliative patients with palliative care needs at end of life, we had a mortality of 18%. So you see the burden of NCD in the IPD. And then remember also 40% of the patients with NCD in Homa Bay Teaching and Faro Hospital IPD, they came from Homa Bay Town sub-county. So because of this increase, a decision was made. You can go to the next slide. A decision was made to open an NCD activity in 2 primary health care facilities. Remember level 1, level 2. Level 1 is the community. So we went to level 2. One of the facilities level 2. It's called Nyalinkinyi dispensary. And also the other one is called Maridi Health Center. So it's a level 3 facility. So as remember from our presentation yesterday, we hardly get a doctor in level 3. Level 2, there is no doctor there. So, and Also, as Purity said about the guideline, we had to come up with a simplified protocol. So our objective was, the first one was simplification, using simplified protocols, the algorithms. We mostly use them in MSF. And the other one was to create a continuum of care. By simplification, we were in the 2 primary care facilities. We are supposed to see patients who are stable, and then those with complications to go to level 4 facility. That time, Homa Bay Teaching and Referral Facility, Referral Hospital was level 4 hospital. So, remember, there are what we presented yesterday, management of NCD in Homa Bay County till to today. It's physician driven. It's the whole country, is not on Homa Bay County. Physician driven, and it is done in the MOPC. MOPC is the medical outpatient clinic. So then there is a long waiting time, and remember, this is the county referral hospital, and we have more than 1.2 million people living in Homa Bay. So that's why we decided to decentralize. So we went with simplified protocols. So also we created a continuum of care such that the patients, to decongest Homa Bay Teaching and Referral Hospital, the patients who have complications to be seen in Homa Bay Teaching and Referral Hospital at the central level, and then for those with NCD and stable, or they don't have complication, to be seen at the 2 primary healthcare facilities. Then also for, one day we are going to leave, and also the other thing is, as OCP, we are proud that we decentralized HIV care, and it was adopted by the government. So we also think we need to make it as a community-based, self-sustainable component to ensure that even after we leave, it will be fully transitioned to MOH. That's why Edward is going to, also on Monday, we are going to share what we do with our patient advocacy group. The next slide. So we focus on 6 diseases: diabetes, hypertension, epilepsy, sickle cell disease, asthma, and COPD. And the scope of intervention includes, of course, to do diagnosis. We also do technical support, like we mentored the HIV clinic clinicians so that they're able to manage HIV patients who have NCDs. The other thing is, of course, monitoring and evaluation, because also we realized in MOH they don't have data tools, even patient cards. Like for sickle cell, there is no sickle cell data. We don't have any, sickle cell indicator. We don't have any data collection tool, or that is the patient card. So some of them came from MSF. Even for epilepsy, even for asthma, the patients are just using the normal patient card. So we introduced some data tools, and also currently we are using the chronic disease database, the MSF. But we use MOH data tools. Everything we use is MOH. It's only where we don't have, we bring the MSF. Then also we do the basic point of care test. We have a sample rider who collects, like once we take the samples for, let's say for creatinine, for HbA1c, we have a MSF lab in Homa Bay Teaching and Referral Hospital. So we have a sample rider who collects the samples and takes them to the lab. But of course, something like HB, something like random blood sugar, we just manage it within. It's just the testing is just done within the point of care. Then also we have another component, therapeutic education, the patient support, education, and counseling. This is not mental health. This is to ensure patients understand their condition. And then how, once they understand their condition, they'll be able to modify their lifestyle. So we have a counselor. We also have a patient, PSEC, the Patient Support Education Counseling Supervisor. And also the counselor also does individual counseling, that is, does the therapeutic education. Once we have a new patient, also a patient who has been absconding, a patient who maybe was lost to follow up, a patient also maybe we see the controls are not happening, or even a patient who request, we send them to the counselor for therapeutic education. Then also we have integrated with HIV clinics. So we know how it is designed. A patient, 24% of our patients in these NCD clinics, they are living with HIV. So what we do is we have from infrastructure, we created a room next to the CCC, and then patients are given a SIGO appointment. Then also we did trainings to the clinical officer, the nurses from the HIV clinics, so that they are able to do the consultation. The patient doesn't have to go to the 2 consultation rooms. So patient receive a SIGO consultation. The other thing is also for data collection. For HIV they use software. So also we bought some tablets. We are able to do. Our clinicians from now the NCD side, they are also able to manage the patient on NCD and also HIV. The next slide. So we have more than 2,000 patients. By Q1 we had 2,186 active patients, and majority of our patients are living with hypertension. So you know some patients have both, like 17% of our patients they have diabetes and hypertension. So that is how the disease profile looks. You can see 53% of our patients, they have hypertension, 6% have sickle cell, 9% have epilepsy, and 8% have asthma. For COPD, we only have 1 patient. So I grouped it in asthma. Yeah. Next slide. So, as I said, yesterday there was a question about pediatric NCD. So you can see the blue one represents pediatrics, less than 14. Of course, pediatrics is less than 12. But even at our Homa Bay County, pediatrics is less than 14. So you can see the blue one, especially for sickle cell, epilepsy, asthma, and type 1 diabetes. We also have pediatric patients. Then for the origin of our patients, as I said, we went to Homa Bay town, sub-county. But now we have a challenge. We are getting patients from other sub-county because our drugs are free. There is also a perception in the community MSF drugs are potent or strong. So patients are coming from even other counties. You can see we have some patients coming from Migori County, others from Kisii, and even a few from Kisumu County. Because there is that perception MSF has the original drugs and the quality, but also the quality of care is good. And as we said, access to care is a problem. Like for what happens in MOH, there's just, even in MOPC they'll see you, but most of the time the drugs are never available. So one has to go buy in the pharmacy, in the community pharmacies outside, which is mostly expensive. And also the quality is not, we don't have a regulatory framework for pricing in the country, but for quality we have, but sometimes we know like we have fake drugs sometimes in the market. So the next slide. So this is just to show you the problem, and because of this problem, we have in 2023 we introduced the differentiated service delivery, the DSD, which is for those who have worked in HIV programs. It's there. This means patients who are stable, like for HIV, patients who have hypertension or diabetes or both conditions, and they are stable, and they have been in the program for more than 6 months. They have undergone therapeutic education, and of course they consent. They are told not to come for monthly appointments, because usually patients come for monthly appointments. But now, if they are stable for diabetes and hypertension or both conditions, we introduce the DSD model in the Q3 of 2023. So we have I know standard of care is not recognized by WHO as a DSD model, but because our cohort, you know, for NCD we saw in the morning, there is also the age factor. Some of the patients, they feel they must, especially the old ones, they have to talk to someone when they come to the facility. They will ask you, I cannot come all the way from home to come to the facility. Then I fail to talk to the, to the nurse. So for stable patients, they are normally seen by the nurse. So the nurse does standard of care. So they are given 3 months refills for their drugs. And for those who choose not to go to the nurse, and also they don't want to join a group, they go straight to the pharmacy. So they are also given 3 months. So the idea is they come from home, they go to the nurse, to the pharmacy, the dispenser gives them a prescription, gives them dispenses the medicine, sorry for that. Then we have group-based. There are those patients, I'll start with the community-based. Let's say like we come from Kisii, this region, and we are stable, we have diabetes or hypertension or both conditions. So we just agree, like tomorrow is which date? Let's say on 15th next month, we meet here. A CHV will come with our medication, brings our medication, and does blood pressure measurement. Although the blood pressure measurement is not needed, but we are doing an operational research. I'll talk about it. So does blood pressure measurement, and then within 30 minutes does maybe some health education. Within 30 minutes we should all go to do our activities. So that is the community based. So but because of, you have seen that patients are widely distributed between sub-counties, even from a sub-county, you know, it's like a district. So it's tricky because sometimes you find one patient comes from here, another one from, I think Kericho, you know Kericho where we stopped, another one maybe from the tea plantation. So it becomes tricky. So, but this is still a model that we're implementing. The other one is facility-based. It's just the same, but this one they come to the facility every 3 months, and then they meet maybe at a tree, CHV and counselor. They come, they take their blood pressure measurement, they do health education. In case they find something abnormal, we did a training for them. They refer them to the clinic officer. So, and then, so this means that patient will have 1 year, 1 consultation by the clinic officer per year. 1 consultation per year, but the other 3 months they'll be meeting either a CHV, or if they want to go to see the nurse every 3 months. Can you go to the other slide? So I think I was explaining this, like when these are the building blocks for a DSD. So when they meet the clinic officer once a year, but for drug refills 3 months, every 3 months, and then it's the clinic officer and the nurse. We have a pharmacy team to do the fast track, of course also to prepare the medication, and CHPs, counselor. Counselor is the one who does the therapeutic education, and in the community, of course, is a CHP. For facility-based and also facility-based and fast track, they meet in and also standard of care. Of course, they come to the facility and are the what you can see. So I think I already talked about it. So how many patients do we have in our DSD? Next slide. So in total we have 530 patients in our DSD. Of course, standard of care, once a patient qualifies, where you can see it has the high number. Of course, there is that factor that, especially the old patient, they want someone to talk to. That's what they told us. So, but the reason as to why you see the high number is once a patient is eligible for DSD, what we do, they are put in standard of care, awaiting maybe if they chose a facility-based group or a community-based. So they're immediately put in standard of care. Another problem we had in a dispensary, we don't have a pharmacy personnel, a dispenser or a pharmacy technologist or pharmacist. So MSF has been forced for us to implement fast track. This year we have been forced to recruit dispensers, and also we have been forced to do infrastructure development, like to renovate some rooms so that we can implement the fast track, because we know that majority of the patients, they want fast track. So we know that the data is going to change with time, because this has just started in Q2. Yeah, and already we can see that patients are moved. So patients have a right to move from one group to another one. Today they can be on fast track. If next month they feel they don't want to be fast track, they have that liberty. So for operational research, you can see also the number of groups. So we are also doing an operational research on the feasibility, acceptability of this, especially for hypertensive patients who are on a fixed dose combination. Maybe I'll talk on this on Monday when we are looking at one of the cases, because Spirit will look at diabetes. So I'll talk on how we are implementing fixed dose combination. So we are doing an operational research on this. So it's a qualitative study. Next slide. So this is so DSD is one of the approaches that it's something new in Kenya, like for NCD, and we want it to be adopted by MOH. So for MSF, you know from how it was presented that the national MOH does the policy guideline. So MSF, we have an advocacy manager, also from coordination medical department. We are members of various technical groups. Like when the diabetes guideline was reviewed last year, we participated and we gave our input for simplification. Because I talked about simplification. Maybe there's something I forgot to talk about. Also, although he's going to talk more about it, we have a community engagement manager. We work with the CHPs. We do health promotion, service promotion. Sometimes we also go, like for sickle cell, because the cohort is the pediatrics, the young population. We also go to school, create awareness in school, and also for teachers to understand even how to help the pupils who have sickle cell, or students who have sickle cell. So, and maybe that is all for our two primary health facility, but because of NCD, also for OCP, as I said, we have a ward. We are supporting the IPD. So there is also, how do we get our patients? So we get our patients from the community mobilization, service promotion. Sometimes we do screening in the communities, including like market days, but also from IPD, we analyzed our data in 2015, and we realized that 20% of our patients were dying within 9 months of discharge. And also we realized half of these deaths, they happened within that 5 days of discharge. So it led us to a question, what can we do? We went to MOPC, because a patient with a chronic disease is supposed to be discharged through the MOPC in the normal MOH structure. So once we went to the MOPC, we found that there is a long patient waiting list, and then long appointment time. Then MOPC is only opened once per week. Then MOPC has the specialist, that is the physician. They only see at most 25 patients. So, and you can imagine this is a county hospital. So, and then because then Prof is shaking his head. Then also, because also we have the surgical outpatient clinic, we have the pediatric outpatient clinic, we have the gynecological. Yeah, so that is how the MOPC works. So we realize they are dying because they are being given, like come in December, and then the person has just been discharged, needs to be reviewed within 2 weeks. So what we did, MSF opened a post-discharge clinic. So patients are followed up for 2 months until they are stable. So once they are discharged today from the ward, they go book the MOPC. Then, because they will be given, we know they will be given a long appointment time. As they wait for that long appointment time, we follow them up in the post-discharge clinic, what we call the PDC. The next slide. So in the PDC, we only see patients with chronic diseases, advanced HIV, and also advanced HIV, and also NCD-related conditions. So this is, I know the graph is, okay, it's maybe we should have extended it. So by last year, we were seeing 105, an average of 105 patients per month. So once the patient goes through the PDC, after 2 months, they are also informed of the 2 primary health care facilities that are MSF supported. So if they don't have complications, they are also given that opportunity to go get enrolled in the 2 facilities. So maybe you can go to the next slide. So this shows the importance of the PDC. You see, like here, this is patients who are discharged through the PDC, but they were enrolled. This one discharged through the PDC, but because it's voluntary, they never went to the PDC. So this represents the mortality. So you can see the PDC is working. You see when they don't go to the PDC, the mortality. Also, these are like malaria patients, those with they don't have a chronic disease, and then they don't need to go to the PDC. The same, this is for 2020. You can see the PDC is working. Like if a patient is eligible to go for PDC and they go to the post-discharge clinic, the mortality goes down. So the next slide. So also in our IPD, we also have, as I said, 18% of our deaths last year, they were end-of-life palliative care cases. So in Kenya, palliative care, it's on paper, but practically, I know some counties are doing something. Like in Homa Bay, we have a palliative care unit with 1 nurse, and basically there are no drugs. So MSF, we saw like, because we're having palliative care cases who don't need to be admitted in the ward because they just need to have dignity. So we started a palliative care activity And then we have another problem is our medicine, the way our doctors, our clinic officers, our nurses, the way we are trained is to save or prolong life. So there was an ethical dilemma when maybe it's an expert doctor from Europe and from Asia, and then is telling our local doctor, like, this patient, we don't need to do aggressive management because he's head of life and will eventually die. So it even brought a very bad commotion because of the ethical dilemma. Like, for us, we are supposed to save life. We can even be sued that we let this person die, or the media can come say that we just observe this person. So they would even try to resuscitate someone who is bedridden and is at end of life. So because of this, we have our palliative care referent. He came, did a training to the staff, but because we work in the MOH facility, and for acceptability, we went to the palliative care unit of MOH, and they came and did a training to everyone plus the consultant. Also, in the way we practice medicine, okay, maybe a medical specialist in Kenya is called a consultant. So his word is the law in the word. So if you say, give this drug, and you come and say this is end of life, it's a problem. So we needed to change the mindset of the healthcare workers in the ward. So a training was done, and we also started a home-based care palliative program. It has a supervisor, a nurse, a counselor, and also they also have a mobile van. So and you can see by last year they did 158 home-based care visits. We only do home-based care visits for bedridden patients. So yeah, you can see the magnitude of palliative patients living with palliative care needs. Like last year, there were 344. So thank you so much. So I'll let Edward add on the NCD, on the primary healthcare facilities.
Thank you so much, George. I have a little time, but I will want to say that, as I always continue to say, we are a rural county. And we don't have that style of Embu because we don't mingle so much with fruits. We only mingle so much with fish. Like yesterday, I really enjoyed eating the lunch because fish was part of it. So thank you. I will want to talk about MSF, what they have done so much. Remember, I'm a patient. So I just want to bring a picture of what they have done to help us manage NCD. When we started with the fundamental thing here, if you want to succeed within a community, then the first people that you must be engaging with are, one, when on health, you must engage with the community health workers. Because these people are usually part of that community. And therefore they know so much because they do door-to-door things like that. When we started as activists, when we started as advocates of NCD, the first thing that happened was we were trained. And remember where I'm coming from, we are more of activists. These other people will understand, will know that Luos are very activist. They are good in that. So the moment that I realized that the government is not doing right for me, then I will have a platform to start activism. And that was not helping us. Because it is like we are having a collision with the MOH. So when we went, the first thing that MSF did was to bring trainings, capacity building. So we were trained. We started we were around 24 of us when we started all this. After we have gone through all those normal, and now our situation has been stabilized, now they started training us. on whatever has been seen here, communication, on policy, on budget, which I will be presenting later. Now, I want to talk about DSD. As my colleague, as George has put it, it has really helped us as NCD patient. And some of these things, when we started, we had a problem with the community health promoters. The reason being, they are recognized by the government and the county government, but here we are coming as advocates of NCD. And now when we go to the community, we regard of the protocol, we were talking with people, because now I'm very concerned. I have to talk with my few friends about their condition, things on NCD. So I will refer them. Literally, I will tell them, my friend, if they are convinced, I will tell them, please, go direct to the hospital. Now, the health promoters were seeing us as now people who are coming to supervise them. Then the collision started from there. So what the MS did is to collaborate both the patient and the promoters so that we talk from one point. Then that helped us a lot. Now because we will be talking of the support groups that I will be mentioning some few, now we are collaborating and working as a group. That now helps us in so many ways. One, you have heard of DSDs. These DSDs on two principles. We have the facility-based. In facility-based, and as George has placed it, we have on our area, we are focused on the NCDs that he has mentioned. One of them being diabetes, a condition that I'm in, and pressure that I'm also in. I'm managing the two. So this one help us in this way. You know, in this, I told you that the MSF are only operating in one sub-county. And within that one sub-county, they are only having two facilities, the Nyalkini and the Marindi. The rest 7 of them, we don't have something like an NCD facility. It means, therefore, there will be a lot of pressure on the two facilities. It means that if we get a new patient from other 7 facilities, we will definitely direct them to the 2 facilities. And then the end result will be, the nurses that are there will be overworking because the number of turnout will be so high. So it means, therefore, there must be a mechanism of actually reducing the attendance of new patients to the clinics. Then the issue of DSD is coming. So we started with a facility-based. In facility-based, what we are doing was, because it is always a burden, an NCD patient must always have a budget for the drugs. But here we are, MSF is helping us, paying and giving us drugs for free. For those people who are still not lucky to be enrolled in the MSF, you can imagine how much they are going to spend a day. Because some of the drugs a day, you will need to spend like 300, in the morning 150, in the evening 150, that is 300. You round it to 30 days, it is about 9,000. That is so much expensive. So the DSD help us now in that the categories that I've mentioned will be coming, the specific day that they are going to agree, in collaboration with the community health promoter. So we agree to talk. So when we come together to sit, we will not directly be going to the nurse, because the community health promoter will be with us. And now on that round table, when we are collecting our drugs, we will be sharing. That is the first advantage, our experiences. Another person will be telling me how he has been coping, what are the challenges and areas to improve. So that is one aspect that help us and always encourage us all together as patients, that when I hear from another patient, then it gives you a motivation that the situation is not worse. Then we, again, during that time, because most of us cannot afford these screening gadgets, so it therefore means that when we go to the facility and we have our DSD, that is an opportunity that we are going to, you check your sugar level, you check your pressure, because you don't have these gadgets. So initially we used to be going 2 weeks in every facility. When you are not stable, you will be booked for 2 weeks. 2 weeks, as I've said, the transport cost alone is too expensive. It means that you will be spending so much just traveling to go for the checkup. But now when they introduce this, and now we are going once, and then once in 3 months, and then literally it was improved to once in 6 months. So when your situation has stabilized and you are okay, now you can go to the second community-based. Community-based means, therefore, that if we have a group of us, for example, we have Homa Bay sub-county, we have Karachuonyo sub-county, where I'm coming from, is a little bit far from Homa Bay, and we are 5 or 6 or 10 of us. We will pick on a day that we will send somebody, one, we can now literally contribute fare for him. He will go and collect those drugs. We will be waiting for him. Then because he has been trained and he understands, and we also understand, then we are, when he comes back, now he will be the one sharing all that and distributing these drugs for us. It will be time, it will be saving our time, it will also help us to save money from transport. So that again was really helping us. Another aspect of what the MSF has really introduced on our side is the aspect of outreach. The outreach here, it means that now the community health promoters and us, we usually go out to create awareness. There are so many groups within our communities. We have women group, we have religious groups, then we have there is another common narrative that is a group that is so common nowadays. It is a table banking kind of a group where so many guys will come together, they contribute fund, and then they pick it. So that is a group you can exploit. So when we are going down there, remember the only one person that is recognized to mingle so much is the health community promoter. Because it is being recognized by the county government, it is also being recognized by the government. So us, we are just working as an advocate of the NCD because I'm a patient. So I want to enlighten and create awareness about these other people. But if you combine the effort between you, the aspect of advocacy, and then the health promoter, and then you identify some of the groups. So when they are meeting, you will walk in. And when you walk in, the health promoter will definitely, because they know him better, they will introduce himself. Now today we have come to do this and this and this, and with me is so and so. So after they have talked about the NCD, and now I will be standing on the aspect that I'm one patient suffering from NCD. And now out of all this, you will be convincing some people and creating awareness. So that is another aspect that we, the MSF, have actually helped us to manage. So the MSF has really helped us. We, in Homa Bay, despite that the two facilities are the ones that are engaging, but the level of awareness as we speak today is much higher than it was in the last 2 years because of the collaboration that the teams have engaged in between the advocacy team, the patient advocacy, and the community health workers. So it has really helped us, and that has made us to create more awareness. Lastly, as I've said, all this help us into reduce the burden, because cost-effective things is like when you spend 1,000 today going for a drug, tomorrow you will need another 1,000. But now is a case where the drugs are brought back to you, near to you through the DST, and now it helps us. So we thank MSF for this initiative, and we are really happy that they are with us. For us, we don't think, as much as we are imagining that they will be existing, but we don't think now they have started that narrative of existing. They really help us during the HIV, and now we are in the NCD. So to us, we know they will be existing, but it is not something that we are anticipating to see very soon, because we are not there yet. Thank you so much.
Thank you. So we are not exiting. We are even planning to go to other 2 sub-counties. And maybe the last thing I wanted to say is we also do, for new enrollment, we test, and they're HIV positive, we also screen for advanced HIV. And maybe some of you are wondering, MSF is doing all this, and we are supposed to respond to emergency. So our presence in Homa Bay, we respond to all emergencies within the western region, including in Kisii. Like recently in Kisumu, we responded to cholera outbreak. Thank you.
Thank you. Allow them to run over because it was important. We heard from both of the missions. Tea is out. We are somewhat late for the tea, but that's fine. Could I invite you to go and get your tea? And if I can ask you to be back by 4:10, 4:10, 16:10, 25 minutes. Choppy. Thank you.
glucometer